and it requires us to do a hospital in-service for employees. And the topic that I chose was preventing and reducing catheter-acquired urinary tract infections in the acute care setting. So we know what a CAUTI is. What's a CAUTI? According to Ferguson, a CAUTI is defined as a catheter-associated urinary tract infection that occurs in a patient who has or has had an indwelling catheter in place at the time or within 48 hours prior to the onset of infection. So catheters place patients at an increased risk for complicated urinary tract infections. This is caused by patient-level factors that compromise the host's defenses. The presence of a catheter and associated inflammation modify the bladder environment and offer a window for microbial colonization and disease. So here's some fun facts on CAUTI. 15 to 25% of all hospitalized patients will receive an indwelling urinary catheter. 35 to 40% of all hospital-acquired infections are caused by CAUTIs, and 560,000 CAUTIs occur annually, resulting in 13,000 deaths per year. So why is this important? Because a CAUTI can increase a hospital bill per patient by up to $600. And if it worsens to sepsis, it can increase that bill over $2,800 per patient. And this can result in $131 million in excess hospital healthcare costs a year. As many of us know, in 2008, Medicare passed regulations that prevent hospitals from receiving reimbursement for catheter-acquired UTIs, making this a very important topic for facilities across the country. Despite research providing proven prevention techniques, incidences of CAUTIs are not decreasing. So the most important thing to be worried about with a CAUTI is to prevent them. There's 4 essential components to prevention of CAUTIs, which number 1 is avoid unnecessary placement, proper sterile technique in insertion, EVP guidelines to manage the catheter care daily, and timely removal of those catheters. Statistics show that 3 to 10% increase, a patient has a 3 to 10% increased chance of acquiring a CAUTI for every day that they have a Foley in place. And that increases to up to 80 to 100% after they've been placed for more than 30 days. Many of us have heard about these unnecessary placements and proper techniques over the years, but one study I found reported that up to 91% of nurses report inappropriate indications for CAUTI or for catheter placement. However, it's not just nurses. That same study reported 87% of healthcare providers also report inappropriate indications for catheterization. So we've all heard of those patients that just want a catheter because it's easier and they don't want to get out of bed, and their IV Lasix are making them go throughout the night and they just want to sleep, but those would be an unnecessary placement of a catheter that we would want to avoid. So what are the appropriate indications then? Select surgical procedures, especially procedures that are involving the patient being immobile, or long surgery times. Accurate INOs for very critically ill patients, especially in the ICU. Relief for acute urinary retention, not incontinence. Assisting the healing of pressure ulcers, especially stage 3 and stage 4. And then end-of-life palliative care for terminally ill patients. So despite convenience, urinary incontinence is not an appropriate indication for an indwelling catheter. nor is IV diuretics, unless the patient is unstable on their feet or unable to ambulate safely to the bathroom. In the cases of incontinence, however, we would consider a female urinary collection device like a PureWick. These are fun. So the benefits to your external urinary collection device would be that they do decrease the incidence of CAUTI infections, and they do help prevent us from unnecessary placement of a catheter. When would we want to use one of these PureWicks? When we don't necessarily need to monitor INO super specifically. When this urinary incontinence that does not have any skin breakdown or irritation, when the person is having difficulty ambulating or doesn't want to use a bedpan, post-procedure immobility, if they're not going to be in bed for very long or we want them up the next morning, this would be a good time to use a PureWick. Or if you're getting minor skin irritation from their briefs. Oh, I wasn't anticipating that being open. So when do we not want to use a PureWick? Well, when we experience urinary retention, we want to use a Foley instead. Anybody who has male genitalia, obviously. Angry or combative, agitated patients are probably going to pull them out. They pull their Foleys out, so they're going to pull those out too. Fecal incontinence without a fecal management system, and then skin breakdown, like if they've already got a pressure ulcer, we want to place a Foley instead of using the PureWick. And then patients who are able to ambulate and get to the bathroom safely, they just need to get up and get to the bathroom. That's just what they need to do. So what is our role? We want to be a nurse champion. We want to, I want to tell you guys about this. About the PureWick. One study that I found in a 386-bed South California acute care hospital implemented the PureWicks on their floor and monitored their usage over a 2-year. They were able to implement the PureWicks nurses were able to implement this intervention without an order from a doctor. And they also allowed their nursing assistants to be able to take them out because of the non-invasiveness of the PureWick. And that really helped alleviate the nurse workload, just having them be able to pull them out. They actually found that they increased or decreased their indwelling catheter rate from 31.7% to 26% over a 2-year span. They increased their use of the PureWicks from 60 to 13,219, and the implementation of the PureWicks decreased their CAUTIs from 8 cases per year to 0. I thought that was pretty cool. So in our case, with nurses, what is our role? We provide the largest part of day-to-day care in patients admitted in acute care settings. We are primarily the ones responsible for interventions. We need to be advocating for our patients by facilitating timely discontinuation of our indwelling catheters. We need to be labeling our Foley bags and the tubing when we insert them, dates and times. We also need to audit our patients daily. Do these patients really still need these Foleys, or can they be pulled safely? We also need to maintain sterile insertion techniques, hold each other accountable for those techniques, and be open to education and new advancements like EVP catheter removal algorithms, which we all have in our policy and procedure handbook, and the automatic EMARS discontinuation stop dates. So some hospitals have implemented automatic stop dates that pop up on the EMR in the morning and say, hey, this person had this Foley for such and such a date. Do they really need them? And that prevents the nurses from having to track down a doctor and say, hey, can I pull this Foley? So how do we do it here at Bird? Well, actually, we are very much on par with EVP if we're following our policy and procedures. We are only supposed to insert when necessary with a doctor order. We also do have the benefit of PureWick. I think many of us probably have not seen them used very often, probably because we just don't have much experience with them, but we do have the benefits of them if we need them. It's up to us to say, hey, let's try this instead of a Foley. Sterile technique, washing your hands and sanitizing before you glove up. You know, I think a lot of us get into the sterile level, we're putting them on and then you're clean, but it's just more beneficial if we wash before we sterile glove. And then provide daily care. We're supposed to be using soap and water daily for peri-care on all of our Foley patients. We should be ensuring that this gets done, and also the use of a stat lock. Research has shown that if a stat lock is placed, it reduces the amount of friction and movement of that tubing in the catheter, and it does show that it decreases the incidence of a CAUTI infection. And irrigation, only with a doctor order and only when necessary. And then nurse-driven advocacy. So what is best for our patient? Is it just easier for us to just empty a Foley bag, or is it really more beneficial for us to try to get them up and moving and get them safely to the bathroom? So we are on par. Our hospital does have policies in place that do line up with EVP. It's just up to us to take the initial steps to be continuing moving forward with advancements in technology and research, and, you know, just being willing to go outside the box a little bit and make sure that we're providing the best care that we possibly can provide for our patients. I really thank you guys so much for your time and your willingness to come and hang out with me and listen to CAUTIs. And we do got this. We are practicing EVP. It's just providing great care to all of our patients. All right. Thank you guys so much. I hope you found it